Ladies and gentlemen, it is with great enthusiasm that we welcome you to the second session of the DiagHub series, dedicated to advancing global diagnostics through knowledge sharing and collaboration. Building on the resounding success of our inaugural session on clinical chemistry, which garnered widespread engagement from professionals across Asia Pacific, Latin America, Europe, South Asia, and the Middle East, we are thrilled to continue this journey of innovation. The first session not only underscored the importance of standardization and risk management in laboratory medicine, but also highlighted the power of international dialogue in driving healthcare progress. Today, as we shift our focus to immunology, we remain committed to fostering a platform where cutting-edge insights meet real-world impact. Together, let us explore the frontiers of diagnostics and contribute to a healthier, more connected world. Thank you for joining us. Let's begin. It is an honor to introduce today's distinguished moderator first. Dr. Akram Abdel Minan served as the Professor of Medical Laboratory Sciences, Hematology and Immunology at the Faculty of Medicine at Alexandria University. He holds a PhD in clinical pathology with specialized expertise in coagulation and blood clotting research. His illustrious career includes leadership roles such as former head of the Clinical Medical Laboratory Sciences Department at Alexandria University and former Director General of University Blood Banks. His Google Scholar profile lists 109 publications with a total of 306 citations and an H index of 9. Recognized for his outstanding contributions, he has been honored with prestigious awards, including the Dr. Mohamed Sal Eldin Award for Scientific Excellence, the University Encouragement Award for Scientific Research, and the Medical Syndic Shield for the Ideal Physician. With his profound academic expertise and dedication to advancing laboratory medicine, we are privileged to have him guide today's discussion. Please join me in welcoming him. Welcome, Dr. Akram Abdel Minan.
Thanks for the nice introduction from Silayawan. I'm very glad to have the opportunity to participate in this academic conference upon the invitation of the famous company Zybio and the International Federation of Clinical Chemistry and Laboratory Medicine. Also, I'm glad to serve as the host of this session. At the same time, I'm also honored to be able to learn and exchange knowledge related to the field of laboratory medicine and immunology through the DiagHub platform today with experts from Iraq and China. Now let me introduce the expert who will deliver the first lecture, Professor Nizar Haddad from Iraq. Professor Nizar Haddad is supervisor of the Iraqi Board of Chemical Pathology. He is the head of Pathology Training Center for Iraqi Board of Medical Specializations in Pathology. He is a senior lecturer of clinical biochemistry in University of Basra College of Medicine. He is a fellow of Iraqi Board of Medical Specialists, fellow of the Academy of Diagnostics Laboratory Medicine designation, and he is also a fellow of the Royal College of Physicians. Please join me in welcoming Professor Dr. Nizar Haddad for his lecture entitled Bizarre Thyroid Function Tests.
Thank you very much, Dr. Abdelkarim, and for your nice presentations. And I'm really glad to join these opportunities with the IFCCs and Zibios to let me introduce some of the interested topic about thyroid function tests. So can I share my screen?
Yes, please.
So my presentation is about bizarre thyroid function tests. Actually, one of the great confusing tests that we see in our daily practice and need to take a look at some considerations. So first, let's the introduction. Thyroid function tests, as you know, are common, yet their interpretations may be challenging. There are a subgroup of patients that present with a confusing or what I call it bizarre thyroid function test. in which their result may be discordant with the clinical pictures, or they are internally incongruent. An example of that, we may face a thyroid hormones that is raised with non-suppressed TSH. In addition, we may face a raised TSH with a normal T4s. So it is essential to carefully interpret thyroid functions in different clinical scenarios. So to go back to solve that problems, let's recap or revisit the basics of hypothalamic pituitary thyroid axis and how the thyroid functions, thyroid hormones action. As you know, the hypothalamic pituitary thyroid axis is regulated by the thyroid releasing hormones, which stimulate the TSH to produce then this TSH will stimulate the T3 and T4 productions. That T3 and T4 will exert a negative feedback loops, and this is crucial in maintaining the euthyroid status. At the cellular levels, both the receptors and the iodinase hormones modulate the actions of the thyroid hormones. As we know that the T3 is the principally bioactive hormones and acting via the nuclear receptors, both the nuclear alpha and beta. So understanding this path of this physiological axis is the key when we are going to interpret the phenomena of the thyroid function test. If we go to the patterns, what we call the bizarres, we will see that some of them are presented with the classical pictures, such as raised thyroid hormones with a suppressed TSH in a classical hyperthyroid, depressed thyroid hormones with a raised TSH in a classical hypothyroidism. But there are other indices or other cases where we can find there is subclinical hypothyroidism, where we find the normal thyroid hormones and the raised TSH, normal thyroid hormone with the low TSH in subclinical hyperthyroidism. But we should not forget the other conditions, such as resistant thyroid hormones, TSH-OMAs, central hypothyroidism, and an important thing, which is the non-thyroidal illnesses. So if we see the center of this thyroid pattern is the normal. Above it is the hypothyroid status, which could be to any of these conditions: autoimmune thyroiditis, thyroidectomy, hypothyroid phase of thyroiditis, iodine deficiency, or congenital hypothyroidism. When the TSH is depressed and the thyroid hormones levels will be increased, the hyperthyroidism or the classical picture of hyperthyroidism emerge, and these are presented by either Graves' disease, toxic multinodular goiter, toxic adenomas, thyroiditis. Drugs may have a role at these levels, and congenital hyperthyroidism. If we expand, we will see that there is an additional 4 entities that need to be addressed, and take a look at them whenever you interpret the thyroid function status. These conditions where the TSH is low on normal thyroid functions, such as in subclinicals, maybe a drug interference, assay interference, or drug interference, normal or decreased with decreasing thyroid hormones. This is maybe due to central hypothyroidism, with isolated TSH or assay interference. Raised TSH with raised T3, T4s, they may be TSH secreting adenomas, neonatal period, and non-thyroidal illnesses. And finally, with subclinical hypothyroidism and assay interference and drugs that may present with an increasing TSH with the normal thyroid. So to make this the approach to these patterns in a systematic way, we should follow the step-by-step interpretation of thyroid function test. So the first thing you will need to address is the clinical context matters. All the time, re-evaluate the patient clinical status first, Are the symptoms consistent with any hypo or hypothyroidisms, or is it euthyroid? Because in cases with low index of hypothalamic pituitary thyroid function dysfunction, this can lead to confusing thyroid function test. Don't forget to consider the ethnicity, the age groups, the gender, and the body mass index whenever you interpreting the TSH, and this should be interpreted at TSH specific reference range. Because sometimes if we overlook the clinical pictures, this may lead to inappropriate further investigations. So the initial steps in every assessment of the thyroid status is to reappraise the clinical status, which will guide the further interpretations. The second thing that we should look at it is the non-thyroidal illnesses, or what is called in some cases sick euthyroid syndrome, which commonly confusing most of the pictures of the thyroid status. And this is occur in acute or chronic illnesses without any intrinsic hypothalamus pituitary thyroid abnormalities. So the axis will be normals, but these are external factors that influencing the conditions. It's characterized by the various patterns. We see that the additional 4 patterns in the thyroid assessment all can be contributed by non-thyroid illnesses. Most often presented with the low free T4s with normal free T4s and TSH. There may be elevated free T4s also occurs, and here the reverse T3 play a role which is usually raised. The mechanism behind the non-thyroidal illnesses is the altered response of the TRH to TSS secretions, the thyroid hormone binding, and some of the literature said that the deiodinase activities may be affected in this condition. TSH may be transiently elevated during the recovery state. So awareness of this condition should be put first when you are going to assess a patient with a thyroid function test, in particular if we have a chronic or acute illnesses. The third part which we should look for is the major challenge that happens with pregnancy. Pregnancy have a significant impact on hypothalamus pituitary thyroid physiology. In addition to that, raised thyroid binding globulins may lead to around 150% increase in the levels of the T4s and compared to the non-pregnant values. So every time we should compare the trimester specific, because in the first trimesters there may be the SHG stimulating the TSH receptors, which leading to the transiently elevated free T4s and lower TSH. Hyperemesis gravidarum in pregnancy can also over the pictures of the thyrotoxicosis and suppressed TSH. Late pregnancy, the picture will be changed, and the free T4s may be dropped down below the non-pregnant references. So all the time when you're interpreting the thyroid function test during pregnancy, take a look of the thyroid function status in addition to the to distinguish the thyroid disorders using other markers. 4 things that you should need to address is the levothyroxine therapy effect. The anomalous can occurs from of the thyroid function test whenever the thyroxine being administered. Normal TSH and the mild increased free T4, possibly in the physiological conditions. Increased TSH deposit high the levels of the T4 doses. So consider malabsorptions is a poor compliance is the main mechanisms. Whenever we see that whenever we increasing the dose, there will be despite that the level of the TSH is going to increase. So maladministrations or malfunction should be considered, such as celiac disease, drug increasing the metabolisms or the deactivation, such as phenytoin, should be addressed, and drug that affecting the thyroid binding globulins also should address. So consider TSH assay interference also as a factors when you are going to interpret patient on thyroid or T4 therapy. Sometimes we may require to do thyroxine absorption test. This is useful when to discriminate between their poor compliance and the failure to absorptions. So the protocols involve the supervised administration of the cumulative doses of thyroxine on weekly basis, and then to monitor the free T3, free T4, and the TSH, both at the baseline and serially post-dosing that. Well, after 360 minutes, this is followed by weekly supervision administration of the several weeks of thyroxines and interpret the TSH normalizations. Inadequate free T4 raise, suggesting a malabsorption status. Drug interactions affect the thyroid function test. Numerous drugs have altered the thyroid function status. They may have direct effect on the hypothalamic pituitary axis, such as iodine can cause hyper or hypothyroidism. Amiodarone, which is common drug in arrhythmias, has complex effect on hypothyroidism, both type 1 and type 2, and thyrotoxicosis. Lithium, in certain cases, psychological conditions can cause hypothyroidism. Thyroxine kinase inhibitors may lead to the hypothyroidism and thyroiditis. So this is a very crucial. When you receive a thyroid function test, to dig into the medical history or drug treatment of that patient. Also, drug may alter the thyroid binding globulins, such as estrogen, tamoxifen, androgens, and we should not forget that displacement of the T3 and T4 from its binding protein. This has happened with common drugs such as aspirins, furosemide, and phenytoins. Heparin maybe have an effect on the displacement also, and there is drug that suppress the TSS secretions such as dopamine and glucocorticoid or somatostatin analog, which should be taken into consideration. Also, metformins, common drug in patients with diabetic, may be reported to have a TSH lowering effect. So carefully inspection the patient or with drug history is very important. In addition to that, there may be in vitro analyzing factors that may affect the analysis of the thyroid functions. Then we should look to how the interference in the assay play a role. And this is very crucial and may interfere with many tests in our laboratories. Most of the first interference is with the TSH assay. And as you know, most of the TSS are immunoradiometric assay or sandwich immunoassay. So interference by any antibodies that are whether human anti-animal antibodies or heterophile antibody that can bridge the gap between the anchoring antibody and the capturing antibody or the labeled antibody, this will cause either false positive or maybe inhibiting it with false negative. In addition to that, the macro effect or they're similar to the macroprolactin, the macro TSH and anti-TSH immunoglobulin complex may falsely interferes with the assay variabilities. So it is very important to take considerations with the TSH assay or interference. The second interference is like with the free T4 and free T3 assay interference. And these are challenging when maybe due to the free or very high bound the hormones. So competitive assay are usually commonly used, And the factor affecting the equilibrium, such as heparin, which is replacing the drug, anti-iodothyroidine antibodies may block the hormones, or heterophile antibodies also can play the role. So to overcome this assay, we may need to do a two-step procedures to overcome the interference in free T3 and free T4 assay. And most of the time, whenever you suspect whether TSH or assay interference or free T4, T3 interference, you should determine the test or repeat the test in another technique on another platform. It is misleading sometimes from certain physicians to repeat the test with the same technique but in another labs. This will not solve the problems, but different repeated tests with other procedures may solve the problems. So another discontent of the T3 as challenging is the resistance, hyper-resistant thyroid hormones, or TSH secreting pituitary adenomas. Both can present with goiters or thyrotoxic features with a clinical overlap in pictures. And the previously inappropriate thyroid ablation is common finding in both these conditions. The degree of the thyroxine increase can be comparables, and this pattern may require a systemic investigations. So it is very necessary to take care when you approach to these conditions, because it is presented with elevated T4s, T3 with non-suppressed TSH. So the first thing to do is to differentiate between the two is with the using of either other tests such as alpha subunit, which is most of the time elevated in the TSH secreting tumors, but not in the TSH resistance. Or we may use another peripheral markers that depend, their expressions or their levels will depend on the thyroid hormones, such as sex hormone binding globulins, which where their hormone levels will be increased in the resistance hypothyroidism in compared to TSH secreting tumors. We may use the TRS stimulation test, and in that case to differentiate between TSH secreting tumor from thyroid resistance, because typically in TSH secreting tumors there is no response or blunted response to the increase, while in the TSH and the resistant thyroid hormones there is a more than 5-fold increase in the TSH levels. And finally, with the T3 suppression test may be of use in some conditions. Other tests that can be used, pituitary MRI will differentiate whether there is a pituitary adenomas, whether micro or micro. And the dynamic tests here play a role with the use of the trials of somatostatin receptor therapies. This will often lead to the response and the low levels of free T4s, while in the resistant thyroid functions there is no response. And the ultimate diagnosis definitely depend on the genetic factors, which sequencing if there is a gene abnormalities in the receptors, and also there is family history in cases of resistant thyroid functions. So whenever you face a discordant thyroid function test, you should follow these 5 steps. First, re-evaluate the clinical history whenever possible. Address the age, pregnancies, thyroxine administration, or thyroxine medications, and non-thyroid illnesses. Reassess the thyroid status, whether it is hypo, hyper, or euthyroid, and decide which of these thyroid abnormalities is likely to discordant. And don't forget to look up for the assay interference, which should be the rules of the clinical pathologist in the laboratory to address these problems and to communicate with the clinicians to better to reach to the to better management of the patient, and finally investigate into a rare genetic or acquired hypothalamus pituitary thyroid disorders. So, in conclusion, interpreting bizarre thyroid function requires a stepwise approach. Understanding the potential pitfalls will prevent misdiagnosis and inappropriate management. And also, and this is very crucial, a collaboration between the clinician and the laboratory specialist to reach to the proper diagnosis. And thank you very much.
Thanks for the inspiring tone for today's first lecture from Professor Nazar Haddad. This beautiful presentation explained to us the importance of hypothalamic pituitary adrenal axis, thyroid axis, and understanding abnormal thyroid test results and the different patterns found and their interpretation. The presentation also highlighted that while we interpret thyroid tests, it is important to take into consideration the clinical patient data, like pregnancy, non-thyroidal illness, levothyroxine treatment, and other drugs like amiodarone and heparin that may affect or interfere with these results. Valuable guidelines are given to ensure the validity of the tests, and the importance of collaboration between physicians and laboratory specialists is valuable. Thank you, Dr. Nazar, for this comprehensive lecture. And now let us delve into the heart of our next lecture from a Chinese speaker, Mr. Zui Lu. Please let me introduce him. Mr. Zui Lu is the product manager of the International Marketing Department of Zybio. He is a member of Chemiluminescence Immunoassay PMT pipeline, dedicated more than 10 years in total life cycle management for multiple CLIA analyzers and novel agents, including cardiac markers, tumor markers, fertility, autoimmune antibodies, and more. He will now share his expertise on understanding high-sensitive troponin I assay, the performance, application, and challenge. Let's give him a warm welcome. Proceed, Mr. Zui.
Thank you, Dr. Akram. Thank you for your kind introduction. It's my great honor to be here to share some insights and some experiences in understanding high sensitivity troponin I assay. In today's presentation, I'm going to talk a little bit more about the performance, the application, and the challenges we face when we are using the high sensitivity troponin I. To begin with, let's take a look back at the history of the definition of MI. Actually, in 1950s, we have our first WHO definition, but in the year 2000, we actually have the ECS and ACS to redefinition the MI, and now we are using the fourth universal definition for MI. But you know, the history of the definition of AMI actually comes in hand with the development of the cardiac biomarkers. In the 1950s, we have the SGOT, we have CK, we have LDH. Then in late 1980s, we have CKMB and cardiac troponin. And right now, in the universal definition of MI, we kind of emphasize more on the high sensitivity cardiac troponin. And in the development of the definition of the myocardial infarction, you know, it actually has changed a little bit. At first, we kind of emphasize more on the CKMB and cardiac troponin. We consider them to be the primary mandatory criteria. But in the third universal definition, things have changed. The CKMB mass is hardly mentioned. And right now, what we emphasize is the cardiac troponin and ECG, of course. So it's like a development and a development of the concept of high sensitivity cardiac troponin. It was proposed, introduced, and now emphasized. So if we look at the fourth universal definition of AMI, we could find that the advancement of cardiac troponin detection technologies has provided a high sensitive and specific method for diagnosing minor myocardial injury in clinical practice. So it's kind of the cornerstone of the new definition for MI. And this really marks a significant leap in clinicians' ability to detect the myocardial necrosis. And it can also substantially narrowing the gap between clinical and pathological diagnosis of MI. And we're using the 99th percentile of upper range limit, and this cutoff, the false positive rate is reduced to below 1%, and this is a huge leap from the previous study. And but however, with the help of high sensitivity cardiac troponin, the relationship between the improved analytical sensitivity and the disease specificity also presents challenges to require like more dialogue, more communication between the lab clinicians and the doctors in the clinical departments. And the ESC actually has done some follow-ups of the first edition. We have also called it the redefinition of the MI in the year 2012. It comes to the conclusion that in a population of patients who were admitted with the diagnosis of ACS, the redefinition of MI actually showed an independent predicting capability for mortality at 10 years. And in their research, three definitions of AMI were used, and it's obvious to find that for different criteria, they have different diagnostic rates. For ST segment elevation, the diagnostic rate for MI is only 30%. But for the old definition, they rely on the rise and the force of CKMB activity. The diagnostic rate is only 55%. But for universal definition, who's relying on the detection of rise and or of the cardiac troponin, the diagnostic rate is above 70%. So that's why it is more emphasized on the cardiac troponin rather than CKMB. And these different criteria really leads to different results. Actually, the management strategies for non-STEMI kind of evolving towards early diagnosis and early treatment, and it can really improve the prognosis of these patients. So it undoubtedly helped to reduce the incidence of severe complications for these patients. And as it previously shows, the CKMB, the criteria that relies on the CKMB, whether it's a mass or activity reagent, that it proves that the CKMB definitions, CKMB criteria might have a less diagnostic rate. That's why the ECS in 2021 start to consider the retirement of CKMB, because as we know it, the cardiac troponin actually has a better sensitivity and a better specificity, and it's not required for detecting peri-procedural myocardial injury, and this cardiac troponin can accomplish it with greater sensitivity. And sometimes it is no longer available in some of the hospitals who's using cardiac troponin to routinely, and they no longer use CKMB. And of course, the more testing of CKMB really cost the patient, and it will take more time for the lab clinicians to publish the results of the patients. So that's why the ECS is considering to retire CKMB in the clinical use. But right now, I think for most of the hospitals who has cardiac marker panels, the cardiac marker panels still consist of cardiac troponin, CKMB, and MYO, and NT-proBNP. But whether it's a high time to retire CKMB, well, it's still left for discussion. But the management of MI needs high cardiac troponin, but with the help of cardiac troponin, we also need to communicate and negotiate, and more dialogue between the lab clinicians and the clinical department. If there's no sufficient preparations and understanding, it could be a result in the disruption and between and dispute between clinical departments and clinical laboratories. But first, what is a high sensitivity cardiac troponin? The IFCC used to have two criteria for high sensitivity cardiac troponin to meet. There are two requirements. The first one is actually the total coefficient of variation and the concentration of sex-specific 99th percentile reference upper range limit should be below 10%. And this is the first criteria. And the second criteria for HSCT-NI is the detection rate in healthy male and female population should be above 50%. So that's the two criteria for HSCT-NI according to IFCC. Then that's why Zybio and its has found a collaboration with one of the top hospitals in Chongqing, and they start this validation of their high sensitivity CT-NI from Zybio in 2023. And in this research, the doctors did not only validate the performance of the Zybio HSCT-NI, they also want to explore the impact of different inclusion criteria for healthy population and the detection rate of the HSCT-NI reagents. So the doctors actually plan to include 1,600 subjects in this research. And the inclusion criteria is that they actually select healthy physical examination population in the hospital who are above 20 years old. But the exclusion criteria is actually more complicated. Those subjects should have no history of heart disease, stroke, tumor, or kidney disease, and there are more criteria. So I'm going to cover in later slides. And from September the 8th to November the 11th, 2023, a total 1,600 individuals aged 20 years or older who went health examinations in the hospitals were included in this research. And after the subjects were excluded by the exclusion criteria, a healthy population of 1,247 were included in the research. 556 of them were female and were male, and 691 of them were female. And this pool of healthy population are then divided into two groups. The first group is apparently healthy group, and they are individuals with abnormalities in some of the following criteria, with lipid profile, with abnormalities in ECG, with abnormality in blood pressure. But according to the exclusion criteria, they do not fit in the exclusion criteria. So we call them apparently healthy group. But we also have the second group. The second group are individuals with all the following criteria, like lipid profile, ECG, and blood pressure of them are normal. So we call them healthy group. And for all those people, for all this population, high sensitivity, cardiac troponin, and NT-proBNP are tested, as well as HbA1c, which is a biomarker for diabetes, and other biomarkers were tested in the hospitals. And the HSCTI and NT-proBNP were tested on the platform provided by Zybio, and HbA1c was performed on HPLC, and other biomarkers they were performed on the existing testing instruments and reagents in the lab departments of the third affiliated hospital of Chongqing Medical University, which is the hospital that is in the collaboration with us. And after we have all the statistics, after we have all the tests, we start to do the calculations. We start to deal with the statistics. First, we remove the outliers. Then we kind of calculate the detection rate for Zybio's HSCTNI. And then we do a mass of the total imprecision at 99th percentile URL for that reagent. But these are some normal validation of the high sensitivity cardiac troponin. We also have some new points of this research. In most of the past research, generally only abnormal individuals with NT-proBNP, HbA1c, and eGFR abnormalities were excluded. But in this research, it's kind of the first research that excludes individuals with abnormal blood lipids and blood pressure and ECG or some X-ray results. And subsequently, we kind of compare the high sensitivity CTNI levels in healthy populations defined by different criteria. So that's the new things about this research. And in the end, we have the results. The detection rate of Zybio's HSCTNI for the overall population is above 92%. And for the male population, the detection rate is 93%. And for the female population, the detection rate is 92%. All of the detection rate is above 50%, which means Zybio's HSCTNI meets the first requirements of the high sensitivity CTNI from the IFCC. And for the second criteria, we actually conduct this experiment according to the EP document, which is EP 05A3. And in that document, it requires the clinicians to conduct the experiment for 20 consecutive days. And for each day, there are 4 tests. And then we actually have 80 results. And if we calculate the total imprecision, which is the total CV for this Zybio high sensitivity cardiac troponin, around the 99th percentile URL for both female and for male, the CV is below 5%. And this definitely meets the requirements from the IFCC, which only requires the CV to be as low as 10%. So the high sensitivity that are provided by Zybio meets the two essential criteria of high sensitivity according to IFCC. But also, we kind of find two interesting facts. The first interesting fact is that the detection rate in population under 40 years old was, slightly lower than that in population aged 40 and above. That means for people for people who's younger, the detection rate could be lower, but for elder people, the detection rate could be higher. And the second interesting fact that we find is that there's no statistically significant difference in the HS-cTNI detection rates among different groups and the overall study population. But however, a downward trend in detection rate was observed when we have stricter inclusion criteria. That's the second interesting fact. Interesting fact we find in our research. But not only we have validations of Zybio's HS-cTNI, we also have done some method comparison with some of the reagents and analyzers in the bucket. We kind of compare the Zybio reagents with Beckman Coulter's and Roche's, and we find that the clinical diagnostic coincidence rate between Zybio and Beckman Coulter is very high, which means the two platforms has a rather high coincidence rate between each other. I think part of the reason is that Zybio actually has a very good raw material research and development team. That's one reason. And the second possible reason is that Zybio shares the similar methodology with Beckman Coulter, who's actually using ALP for as label and using AMPPD as a substrate. To sum this up, actually, Zybio's HS-cTNI actually meets the requirements of IFCC, of the IFCC's high sensitivity cardiac troponin. The first criteria, it's the CV around the 99th percentile URL is below 10%. And the detection rate among male population, among female healthy population, the detection rate is above 50%. So it can be called a high sensitivity cardiac troponin. But what can we do with high sensitivity cardiac troponin? In the fourth universal definition of MI, which is the current definition of MI, in that in this paper, actually, we can see that the clinical definition of MI actually contains two parts. The first one is you have to find the presence of acute myocardial injury, that detected by abnormal cardiac biomarkers, especially high sensitivity cardiac troponin. And of course, the patient has to exhibit some evidence of acute myocardial ischemia. And then with these two combined with the clinical symptoms, it can actually fit the criteria for MI. But the criteria for myocardial injury is actually simple. The detection of the elevated CTN value above 99th percentile URL, well, this will be defined as myocardial injury. But we also want to do some follow-up of the patients who has myocardial injury. We will probably draw the blood samples from the patient after 1 hour or after 3 hours. Then we will see if there's any fluctuations of the cardiac troponin levels of the patient. And then we will kind of differentiate the myocardial infarction into 5 types. The type 1 and type 2 are the most common myocardial infarction in clinical use. And then we have type 3, who's very acute. And we have type 4 and type 5, who's probably because of previous treatment of the heart. And we have this model for interpreting a myocardial injury. If we find elevated cardiac troponin values above 99th percentile of URL from the patient, then we could assume that this patient suffers from myocardial injury. And if the level of the troponin rises or falls rather above a certain range, and if we find this patient suffers from acute ischemia, then this patient could be acute myocardial infarction, and depends on the course of the MI, we can differentiate this acute myocardial infarction into type 1 or into type 2. But if we find no acute ischemia in the patient, well, this could be acute myocardial injury rather than myocardial infarction. And this could be because of acute heart failure or could be because of myocarditis. And if the troponin level is stable, this could be because the reason that the cardiac troponin value elevates is probably because of chronic myocardial injury. This could be because of structural heart disease, or it could be chronic kidney disease. And this is the algorithm or the model that we use in defining whether it's a myocardial infarction. And also, the IFCC has published papers of the management of ACS in patients presenting lung STEMI. And in this paper, we can find that after the arrival of the patients, it's recommended to perform ECG in the emergency room. And then we kind of draw the blood from the patients at 0 hour at the arrival. Then we draw the blood after 1 or 2 or 3 hours, and that we use that blood sample to be tested for high sensitivity cardiac troponin. And with the help of ECG results and with the help of high sensitivity cardiac troponin, we will know that whether the patient is suffer from UA, or it could be lung STEMI or STEMI. And Chinese doctors has also done some research, has also made progress in the diagnosis of chest pain. As we know that the cause of chest pain can simply be divided into some cardiac disease, or it could be because of pulmonary embolism. And since we are kind of retiring the CKMB, we want to put new cardiac markers in the cardiac markers panel. So we kind of first test the cardiac troponin, and then we test the anti-proBNP or BNP, and we add D-dimer into the cardiac markers group. By the D-dimer, we will know that whether the patient is suffering from like MI or probably heart failure, or this patient is suffering from pulmonary embolism, which is problems from the lungs. And then the doctors has reached a consensus, and they have published the papers that justify the use of anti-proBNP and D-dimer and high sensitivity cardiac troponin altogether. So, what is the difference between high sensitivity cardiac troponin and the contemporary cardiac troponin, which is also known as the conventional cardiac troponin? Well, actually, high sensitivity one actually has a higher negative prediction value for acute myocardial infarction. And also, the levels of high sensitivity CTN can be interpreted as quantitative markers of cardiomyocyte damage, which means if the elevations of the high sensitivity CTNI is beyond fivefold of the upper range limit, it means that the positive prediction value for acute type 1 myocardial infarction is above 90%. But if the elevation of the high sensitivity cardiac marker is only like threefold of the upper range limit, well, the positive prediction value for AMI is somewhat at 50% or 60%. So, according to the levels of the high sensitivity CTN, we can know that we will have different positive prediction values for the type 1 MI. And the rising and falling of the cardiac troponin levels will differentiate the acute SNMI from the chronic cardiomyocyte damage. And this is the benefits of the high sensitivity cardiac troponin. But if we want to transition from the contemporary cardiac troponin to the high sensitivity cardiac troponin, there's work to be done. So the JAG actually has published a paper about the recommendations for the institutions who's transitioning to high sensitivity troponin testing. In this paper, it actually covers the rationale and benefits of the high sensitivity CTNI, and it also tells the laboratories, tells the work should be done there by both the laboratory clinicians and the doctors in the clinical departments. And also, of course, for different departments, for different laboratories, they have different implementation strategies. Let's take a look at some of the aspects of some of the considerations that the laboratory clinicians should be considered. The first one is whether to choose CTNI or CTNT. Actually, these two biomarkers are close, but they do share different mechanism, and they do share different degradation mechanism. And the left ventricular myocardial weight in patients with renal failure is more correlated with CTNT, and so CTNT might have a higher positive rate. But these two biomarkers serve the same purpose if they are high sensitivity one in clinical use. So in short, the lab clinicians can choose both CTNI or CTNT as they wish. And if we are talking about the quality controls for cardiac troponin, for the contemporary cardiac troponin, we only need 2 levels of quality controls, but it's a little bit different story for high sensitivity cardiac troponin. For the high sensitivity one, we recommend 3 levels of quality controls. And with the help of 3 levels of quality control, we can do a better quality control for the high sensitivity one. And of course, we want to attend some of the EQA program that is provided by authorities or by some third-party controls. And then when it comes to the communication and the dialogue between clinical laboratories and emergency department, this paper also gives you a central illustration on the algorithm for the transition to high sensitivity cardiac troponin testing. So on the left side, these are some questions that should be asked to the clinical laboratories during the preparation. And on the right side, these are some questions that should be asked to the emergency department during the preparation. It includes like, do clinicians under the basic concepts of how high sensitivity troponin differs from the previous troponin method, or do the clinicians understand the distinction between injury, myocardial injury and myocardial infarction? So these are the regular questions that should be asked during the preparation for high sensitivity cardiac troponin. But in the end, by the end of the day, what we can do to make the best of the make the best benefits of the high sensitivity cardiac troponin is that we got to use a reliable and trustworthy testing system. And of course, this trustworthy testing system should be validated for its high sensitivity. And second, we have to ensure that in routine, we have to keep a proper daily or weekly or monthly or frequently maintenance of the instrument. Thus, we will have a trustworthy testing system at hand. And then probably we have to implement a 3-level of internal quality control rather than 2 levels of quality controls for the high sensitivity cardiac troponin. And of course, for our laboratory clinicians, we have to prepare ourselves. We have to possess the ability to identify and address abnormal results with high sensitivity cardiac troponin in response to some potential clinical concerns or some potential clinical complaints. But no matter what, we have to maintain the communication. We have to maintain the dialogues with the clinical departments. In some of the top hospitals in China, the lab clinicians has frequent meetings and frequent dialogues between the laboratories and the clinical departments. And I think we should have a system that puts the clinicians and the doctors from the clinical laboratories together to communicate and to have dialogues about the application of the high sensitivity cardiac troponin. And through that, we can make the best benefit of the high sensitivity cardiac troponin. So that's all for today's presentation. Thank you. And let's get it back to Professor Dr. Akram. Thank you.
Thank you, Mr. Zoe, for the shedding light on the high sensitivity troponin ISA. It was an excellent presentation that took us in the ride through the history of myocardial infarction diagnosis and the value of sensitive tests in early treatment. The presentation showed us clearly the superiority of cardiac troponin assay over other diagnostic lab tests, and explained how Zybio high sensitivity cardiac troponin reagent was validated and how it meets the IFCC requirements for high sensitivity cardiac troponin. Your presentation showed us the difference between types of myocardial infarction from type 1 to type 5, and they were explained regarding the mechanism, causes, features, and diagnostic criteria, primary management, and the better performance of high sensitivity cardiac troponin over contemporary cardiac troponin in their diagnosis. The high sensitivity is over the contemporary. The importance of high sensitivity cardiac troponin in the diagnosis of myocardial infarction among patients with unstable angina and those with non-ST elevation acute coronary syndromes, and in rapid rule in or rule out algorithms was discussed in this marvelous lecture. We also received important recommendations regarding transition from contemporary to high sensitivity troponin testing, the choice between troponin I and troponin T, and guidelines to the quality control material concentration used, guiding us to make the best of high sensitivity cardiac troponin assay. I thank you very much, Mr. Zoe, for this valuable information.
Thank you.
Now,
thank you, Professor.
Now it's your turn. We now invite all participants in this webinar to engage in an open discussion. Please send your questions through the chat box and our speakers will answer them. Join in and let's exchange ideas together. The first question is for Dr. Nazar.
Yeah.
During different periods of pregnancy, TSH and the free T4 present different patterns compared to the non-pregnant state. In addition to the trap you mentioned for the auxiliary diagnosis of Graves' disease, are there other indicators or examinations can help us distinguish true thyroid disorders during pregnancy? This is the question. Dr. Nazar.
Thank you very much. Yeah, thank you very much, Dr. Akram. Very nice questions. Actually, pregnancies is very crucial issues in the interpretation of the thyroid function test. So when you going to interpret the thyroid function, start with the trimester-specific reference range. This is the first steps, trimester-specific reference range. Then the next steps, we try to look for other parameters that are going to not to be greatly affected or as a leading in the cases of different thyroid conditions, such as we mentioned the example, just an examples of the TRAB, which is thyroid receptor antibody. In addition, you can use the thyroid peroxidase antibodies or thyroglobulin antibodies to diagnose, for example, Hashimoto thyroiditis or other conditions. We don't forget that the use of other utilities such as ultrasound of the thyroid to whether to differentiate different clinical conditions and to correlate things with the scenario on the obstetric status of the patient. And in rare cases, the reverse T3 may play the roles in the issues of thyroid disorders in pregnancies, such as non-thyroid illnesses and others. So these are the crucial rules. So thyroid antibodies or TBOs or TGAs can also add it to the panels that we have in the thyroid, and all the time you should refer to the reference range thyroid function test. Thank you.
I agree with you. The clinical data of the patient is very important together with the laboratory tests. The second question is for Mr. Zoui. What's the clinical significance of using 99th percentile cutoff in high sensitivity cardiac troponin assays rather than the 95th percentile cutoff?
Yeah, great question. Thank you. Thank you, Doctor. And for some other biomarkers, we are using the 95th or percentile of the cutoff. But for high sensitivity one, we actually use the 99th percentile URL because you definitely wonder the difference. But the actual fact is that the 99th percentile really helps us to vote false positive. In other words, it reduces the chance of labeling healthy people as having probably a myocardial injury. And if consider this, if we use the 95th percentile, we'll pick up more people with slightly elevated troponin levels, but these people have no myocardial injury, and that could lead to unnecessary testing or treatment afterwards. So in short, the 99th percentile provides a standardized and reliable threshold that is recommended by the ESC by the universal definition of MI, because it can really balance the sensitivity and the specificity. So it helps the clinicians to identify the true cases of myocardial injury. But of course, we have to interpret these results alongside with like clinical symptoms, like whether this guy has ischemia, and alongside with ECG and other like such as image findings and other results. So this is my answer to the question.
Thank you, Mr. Zoe. Once again, we refer to the patient clinical status when interpreting any test. Thank you. The third question is for Dr. Nazar.
Yes.
For patients who have undergone radioactive iodine therapy or thyroid surgery, thyroglobulin testing may be interfered with by thyroglobulin antibodies, leading to false negative results. Are there corresponding correction methods or alternative indicators, such as the thyroglobulin to thyroglobulin antibody ratio, for such interference to improve testing accuracy? How should the thyroid status of such patients be dynamically monitored in clinical practice?
Okay. Thank you very much, Dr. Akram. Very challenging issues of testing thyroglobulins and thyroglobulin positive, thyroglobulin antibody positive patient. This is very challenging issues, and this is one of the interference that affect the thyroid immunoassay actually. Regarding the ratio of the TG to TGA, this is still an experimental and run in very few studies. It could be tools, but the disadvantage is that there is no standardization of the materials between the different platforms, and in addition, there is different methodology run by different the TGA for and the thyroglobulins. So we cannot depend on such an entities. So what is the recommendations for to follow up your patient with the thyroglobulin antibody positive? In that case, to follow the levels of the thyroglobulin antibodies every 6 or 12 months, where there is decrease in the remission and the cases of remissions. And if you notice that these antibodies re-rise again, this may be an issue. The second thing, you may look for another diagnostic tool, such as ultrasound. Neck ultrasound may take an abnormalities pre-emergent, but this require gross returns. But we have an emerging test which is also an immunoassay. We are in the second generation of the thyroglobulins, but there is additional experiment or technique that try to do pre-treatment to the samples with thyroglobulin positive antibodies. So in that case, they try to remove whatever interference that will interfere with that assay. This is an article that has been published 2023, and they reassess the thyroglobulins using chemiluminescence immunoassay. That technique will get rid of most of the thyroglobulin antibodies, and in this case, it will not interfere with the method. This is called ITACT thyroglobulins. And there is additional the gold standard technique of us, which is the LCMS techniques, which try to accurately determine the level of thyroglobulins. In that case, you can solve the problems, or you can follow up the patient with the thyroid or thyroglobulin positive antibodies. So I think the gold standards method is to go for these markers separately, whether the use of the TGA titers trend or the use of the thyroglobulin, the LCMS method for the thyroglobulins. This will solve the problems. And thank you very much.
Thank you, Dr. Nazar. My fourth question is for Mr. Zui. Does the use of high-sensitivity cardiac troponin increase the positivity rate? Are these truly positive results? How should clinicians interpret them?
Yeah. So to answer this question, first of all, the positive rate is somehow a vague idea, but of course we find more like positive results if we compare with the contemporary one. And the use of high sensitivity CTN, the fact that it increased the positivity rates or increased the numbers of positive samples is because it detects rather low levels of myocardial injury rather than myocardial infarction. But not all the elevated high sensitivity CTN results indicate like true myocardial infarction, but it means that there could be some myocardial injury there. But the cardiac troponin has a very high specificity, but the specificity is towards the myocardial injury. And the high sensitivity actually, the high sensitivity CTN can actually be elevated due to other causes like heart failure, like kidney dysfunction, sepsis, and some other diseases. And the clinicians should not interpret this result to a myocardial infarction, but it should interpret this result with full clinical status, as you just mentioned, full clinical context. And we have to consider with this the patient has abnormal like ECG, if the STAT curve is elevated, and we also have to consider whether there's dynamic changes in troponin levels over time, over 1 hour, over 2 hours, over 3 hours. And a rising or falling pattern is probably more suggestive of acute process. And yes, this is basically the algorithm that from the fourth universal definition of MI. So actually, the high sensitivity really helps a lot in detecting some minor myocardial injury.
So the marker myocardial injury, sometimes it may be not myocardial infarction. So you have to consider the clinical data of the patient and the follow-up of the tests.
Yes, that's right.
Thank you, Mr. Zui. Thank you, Mr. Zui. Today's session marked the second installment of our webinar series, focusing on immunology and clinical diagnostics. We delved into cutting-edge topics with two exceptional presentations from Professor Dr. Nazar Haddad and Mr. Zui Lu. Thank you for you both. A sincere thank for you both, for both speakers, for sharing their expertise, and all participants for your insightful questions and active collaboration. Together, we are re-advancing the frontiers of immunology-driven diagnostics. Stay tuned for further discussions, and thank you all for your time.
Thank you, Dr. Akram, and thank you, Dr. Nazar.
Thank you, Dr. Zui. Thank you, Dr. Akram.
Thank you very much. Thank you.
Thank you, Dr. Akram Abdel Minan. So, ladies and gentlemen, as we bring today's enriching discussion to a close, I want to extend my deepest appreciation to our remarkable speakers and moderator, and to all of our participations. Your thoughtful question and active engagement truly brought this session to life. This marks the successful conclusion of our second DiagHub webinar, and we look forward to continue this journey of innovation with you in the future sessions. So the third installment of our webinar series dedicated to point-of-care testing will kick off this June. Stay tuned for updates. And until then, keep questioning, collaborating, and pushing the boundaries of diagnostics. So thank you. Thank you all, and goodbye.
Bye.
Thank you, Silaya.